Greetings and welcome. Today's topic is patient safety and safety within hospitals as complex systems. So it is first important to notice that there's a direct continuity between the kinds of accidents that we've observed in gas plants and chemical plants and nuclear power plants and the causes and the kind of system dependence of accidents in hospitals and the kinds of things which cost the health and lives of patients in hospitals. Because hospitals, too, are complex systems embedded within complex organizations. So both technology and interactions across technologies, but also complex organizations with information flows across units within an organization, variations in performance, high and low, misconceptions, bad mental frameworks. These are exactly the kinds of factors that we've looked at with regard to safety in a nuclear power plant. But the same kinds of factors are relevant in cases of hospital and healthcare safety as well. The kinds of harmful accidents which can occur can happen both to individual patients, where an individual patient is subject to a wrong site surgery. The wrong lung is removed due to a misunderstanding of the surgical instructions, or for a whole group of patients, a whole group of people who are exposed to bacterial or fungal infections while in the hospital. And it's clear that safety in hospitals has a lot to do with the conflicting priorities and incentives which govern the behavior of hospital administrators. So issues about operating margins, issues about healthcare and hospital reputation, leading to a reluctance to be transparent about the occurrence of accidents. Also, of course, a concern for patient safety, a very genuine and sincere concern for patient safety, but mixed in a concern for patient satisfaction, whether or not that's related to patient safety. There are concerns also for employee satisfaction and the relationship to accreditation agencies. In other words, hospital administrators have a raft of concerns, from profitability to maintaining high-quality accreditation, which they correctly need to be paying attention to as they manage the activities and the processes and the technologies and the individuals associated with the very complex system which a hospital represents. The NASEM report, the National Academy for Science, Engineering, and Medicine, was a very important event in the development of a greater concern for patient safety and healthcare safety in the United States. And both Jim Bajan and Nancy Levison acknowledge its importance from about 2000. But what is really interesting to me is that in spite of the fact that the report is in a lot of ways more sophisticated in its analysis of organizational causes of patient safety and lack of patient safety than the Rogers Commission study of the Challenger disaster was, reflecting the increase in sophistication of sociological and organizational sociology analysis of safety. Nonetheless, the intervening 20 years, I think, would give us an even better basis for analyzing the organizational causes of lapses in patient safety. But the report does take a systems approach to the question of patient safety. Quoting just a few lines, in healthcare, a system can be an integrated delivery system, or a centrally owned multi-hospital system, or a virtual system comprised of many different partners over a wide geographical area. However, an operating room or an obstetrical unit is also a type of system. Furthermore, any element in a system probably belongs to multiple systems. So the point here is that we're really forced in healthcare to pay attention to the system environment in which patient safety and the safety of individual patients and whole groups of patients is determined. What is perfectly clear is that patient safety is the net effect of a complex system within a hospital, or for that matter, within a chemical plant, the kinds of other organizational systems that we've talked about. And the system involved is a set of institutions, rules, practices, training, supervision, software systems, and the day-to-day behavior of staff and supervisors. In other words, all of these are elements of the complex system which eventuates at the bedside or in the operating room. And so we're compelled, if we want to understand how to improve the record of patient safety in the United States or in other national health systems, we're compelled to ask what features of social and legal environment can contribute to making it most likely that hospital administrators will commit themselves to a thoroughgoing culture and management of safety. There are some notorious examples, several of which are mentioned in the report, but we don't need to turn to the newspapers because we're all familiar with the incidents of patient safety and lapses of patient safety in healthcare systems. But a notorious case from a number of years ago at one of the leading cancer centers in the United States, the Dana-Farber Cancer Center, a health reporter for the Boston Globe, age 38, Betsy Lehman, dies of overdose of cancer medication. She was giving multiple times the level of dose that was actually prescribed and died as a result. A second case is an operating room fire. A 13-month-old child is severely burned during surgery. The fire resulted from the use of electrocautery devices in conjunction with concentrated oxygen in use by the anesthesiologist. So two different processes were going on. Anesthesiology was going on, and the actual surgical procedure was going on, and the interaction resulted in a fire. A third example, engineering professor, a real legend, Professor Sam Wu, about 10 years ago, died following surgery as a result of an intubation error, and he literally died as a result of oxygen deprivation. So in order to enhance safety, one view that a person might have, an outside observer might have, I don't think any of you will have that view because you've been sensitized to the importance of looking at safety as an organizational and system effect. But an outside observer might say, well, doctors, nurses, technicians just need to be more careful. So greater diligence on the part of the practitioners is what we need for greater healthcare safety. But contrast that with Nancy Levison's description in one of the articles that you read for today, the system approach to adverse events. She writes, a hospital is a dynamic and complex system interacting as a structured functional unit to achieve its goal of treating patients. One system may be nested within another. For example, a hospital is nested within a larger health system, and an intensive care unit exists within a hospital. And so she argues against the idea of identifying the individual or the small group of individuals or the small group of events which led to the patient death or the patient injury, or in other words, she argues against root cause analysis and instead argues for a system analysis of what permitted the accident to occur. Her more fundamental approach to healthcare safety is to identify the primary constraints which can lead to accidents. By constraint, she means sources of hazard. And then to design what she refers to, she is an engineer, what she refers to as controls that make those hazards extremely unlikely. Medical accidents commonly, and she endorses this view, as does Jim Bajan, but I think every author that we've considered would take the same view, that medical accidents commonly demonstrate a complex interaction of factors, from individual providers to the technologies in use to failures of regulation and oversight. So what are some of the system causes of failure? How can we take a systems approach to patient safety? Well, one observation which Levison makes, and Bajan makes this observation as well, a very important component of aviation safety is that all accidents and serious incidents are thoroughly investigated and the entire industry is informed about the causes so that extensive changes can be designed into the whole system to prevent reoccurrences. This is a point that we've seen elsewhere in our consideration of organizational safety. It comes up under the category of near misses, But it also comes up under the category that we examined when we talked about high reliability organizations, the idea of weak signals. And if a patient has almost been injured by the wrong prescription or a wrong site surgery, a surgical procedure was just called off at the last minute because it's noted that it should have been the left lung and the surgery is scheduled for the right lung, that near miss, no one was harmed, but the near miss needs to be understood and needs to be investigated just as seriously as if the wrong site surgery had actually occurred. We need to consider changes in systems, and this is exactly the thrust of Nancy Levison's point about instituting a different system of controls, a different way in which the processes and activities of the healthcare system proceed. But changes in system might include things like incentives. What are the incentives that the healthcare administrators have, that the surgeons have, the anesthesiologists have, the technicians have? So changes in incentives, payment structures, information sharing. Several of the instances, the cases that are described in the couple of readings that you did, including the heart transplant incident described by Nancy Levison, has to do with information sharing. And then there's the point about patient transitions, which I think you can recognize as being very similar to the handoff of a nuclear power plant from one supervisor to the next supervisor at a shift change. And when there's incomplete or inappropriate or delayed information transfer, that can be a source of an accident in the next period of time. But there's also an important consideration about software. And Nancy Levison in particular emphasizes the importance of reviewing the logic and the user interfaces of the electronic health records which are in place. I think you're all aware that the healthcare system in the United States and elsewhere has been transformed by the use of pervasive electronic health record systems, which are intended to coordinate and centralize treatment plans, patient records, and so forth. But Nancy Levison is very sensitive to the fact that EHRs can themselves be a source of serious error. So what is it about electronic health records which can give rise to mistakes? Levison, writing in a book called Safeware, although it might seem that automation would decrease the risk of operator error, the truth is that automation does not remove people from the systems. It merely moves them to maintenance and repair functions and to higher level supervisory control and decision making. The effects of human decisions and actions can then be extremely serious. At the same time, the increased system complexity makes the decision-making process more difficult. And there are a couple of studies which I've collected of ways in which digital medical record systems have contributed to errors, including a major study in Pennsylvania called the Pennsylvania Patient Safety Authority Study. And what this study has found that medication errors, wrong medication, wrong dose, wrong patient, wrong frequency, can occur at several points during the clinical process where prescribing or transcribing or dispensing or administration of the medication can be caused either by the human being, the provider, or by the patient record system, which has been improperly designed, and so the wrong instructions go to the human provider. So part of the blame, according to the Pennsylvania report, here is a quote from that report: "For this reason, it is important to design a system with an intuitive user interface to minimize the risk for human error. Users should be able to easily enter and retrieve data and share information with other healthcare professionals. When systems are designed without these considerations, patients are subject to undue risk." That description turns out to be prophetic, and in many different digital medical record systems at many different hospitals, including the University of Michigan Hospital, providers and physicians and technicians and nurses have many grave concerns about the user interface, which Epic MRI, for example, presents to them. And Levison's analysis, which is just as relevant in the healthcare system as it is in the safety of space vehicles, remember in the article that we read a couple weeks ago, Her analysis is that we can identify sources of patient patient adverse incidents within the design and the implementation of electronic health records as importantly as in other kinds of glitches within the health system. Here are a couple of quotes from her. However, the EHR often has a poor layout in terms of giving clear orders from the physician to the nursing staff and providing feedback regarding the carrying out of those orders. The EHR design does not provide clear feedback regarding the status of the medications ordered. This is not just a hypothetical concern. This happens in healthcare systems. Another source of systemic sources of accidents, which we've seen before, is the issue of cost cutting and profits. Every hospital administrator is very aware of the razor's edge that hospital economics now depends on. Hospital systems are under intense pressure to remain financially viable under the current constraints of the health payment systems, health insurance, Medicare, Medicaid, and uninsured patients. And so economic viability is a hugely important factor for hospital administrators. But also privately owned and managed health systems have pressure from stakeholders and stockholders to maintain investor interests and maintain company profitability. And so the mantra of efficiency, lean staffing, and cost cutting, these are common management strategies within the healthcare industry, guiding investment decisions and management decisions. And yet there is a trade-off between cost cutting and safety. Quoting from Levison, there is a constant compromise between safety and cost, which permeates every decision in the hospital. This tension impacts staffing levels, equipment inventory, personnel training, and more. Turn now to a third issue that we've seen before. It's safety culture, but in the context of hospitals, it's specifically patient safety culture. Every hospital, every health system administrator would affirm that patient safety drives our decisions. But we've seen that before. We've seen it in the nuclear industry. We've seen it in the chemical and gas industries. What we actually have to be confident is that the organization itself has embodied that commitment to patient safety. And all too often, the answer seems to be that it has not. Because safety culture or patient safety must permeate throughout the organization, and it must inform investment and staffing decisions. And if the investments are not being made to enhance safety, then the statement by the CEO, patient safety is our leading objective, we can't take that very seriously. So the safety culture of the organization, whether it's the University of Michigan Health System or the Beaumont Health System or any other health system that you happen to be aware of, the safety culture must lead providers at every level, from the people cleaning the rooms to the CEO's instructions to vice presidents. Safety culture must lead the providers to a high level of attention and meticulous care for the patient and the conditions in which the patient is treated and maintained. It's sometimes thought that checklists would be kind of a golden bullet in healthcare. And indeed, Jim Bajan argues that operating suites, operating rooms, can be greatly improved by having checklists which every person in the room goes through at the same time. So some observers believe that improvement in safety in aviation through the establishment of checklists before takeoff and landing, this resulting standardization of processes is an important enhancement of safety. Nancy Levison agrees that standardization is helpful for safety, but she thinks that we can't put all of our eggs in the checklist basket. It is not a general solution to problems of system hazard. Instead, vigilant internal and external processes need to examine adverse events, close calls, incidents which could have led to a patient death or injury, and then discover what the constraints or the sources of hazard were, which were violated, and then change the system and processes in such a way that those constraints are effectively controlled in the future. And we've seen before that safety culture must be implemented from the top and from the bottom. But in particular, the top executives really need to have their incentives aligned with the promotion of safety culture. So we have, in fact, observed in other industries, we can see it also in the health industry, if safety is not a genuine guiding priority for the boards and executives of a hospital, if those leaders do not have a sophisticated understanding of system safety as applied to hospitals, then hospitals will not be organized and managed in a way that rises to ever higher levels of patient safety. To achieve safety, the organization needs to direct its resources toward safety with staff, equipment, consulting, and engineering in ways that lead its processes to being as close to flawless as possible. But if efficiency, cost-cutting, and staff avoidance are the leading goals, then safety will not be enhanced. If safety is not given a high priority, then the controls that prevent surgical errors, hospital-borne infections, medication errors, and even dropping patients will continue at, quote, an acceptable rate. And Jim Bajan there's a kind of a side comment which he makes about aviation safety, which is quite discouraging, really, about the imperative toward safety. Because we look at aviation as being the success story of improved safety in an industry. But he makes the point that increased attention to aviation safety was motivated in large part by the sharp increase in the cost to produce jet aircraft as opposed to the conventional propeller aircraft. Aviation could no longer afford to simply build more aircraft. So his view is aviation safety changed when the cost of each crash was so large that the business imperatives led the industry to higher levels of safety. That's disturbing because it really means that the human cost, the cost of accidents to the human beings on the aircraft or the crew of the aircraft or the people on the ground, that was not the guiding imperative. So, lots to talk about in the question of health system and hospital safety, and if only we had 2 hours to have that conversation, I think it would be a very fruitful one.